Thanks very much, Chris. Good morning, everybody. It's fun seeing a lot of familiar faces. And we're going to kind of hop right to it here. If I start running overtime, someone just kind of point at me or yell. But yeah, so we're going to talk about deformity analysis and correction, or how we can make bones straighter. In our outline, I should explain, I have a bachelor's in psychology that I usually kind of keep under wraps. Every now and then it kind of jumps out. So we're going to talk about normal alignment. We're going to talk about figuring out if things are not aligned and how to fix those. Different strategies for getting things straight, and then actually how to do the treatment of it. And that last part, we're going to start probably running out of time a little bit. I've got to say that we're going to be barely scratching the thick rhinoceros hide of this subject. There's a lot of depth to this. This is in my mind, a very fun subject. So if you have any interest in it, hopefully we'll spark some interest and you'll go and pursue this further. Much of this is going to be based on these books here by Dror Paley and John Herzenberg, where they really came up with a good way of talking about the standard measures of how we should look at limbs, what's normal, and how we can define what's not normal. They came up with a nomenclature so we can talk to each other about it, as well as a bunch of treatment strategies. And so there's this textbook, there's a workbook that I use a lot and will be using during this talk here, and also when residents rotate with me, we always have a session where we actually pull out pens and paper and do some of these exercises together. Let's start talking about the nomenclature first. How do we actually talk about joints and limb alignment? This is a little card that Baltimore people came up with. I carry one in my wallet. Most people that I know have one of these so they can pull it out in clinic just to make sure that they're not getting themselves confused. There's another side to this where you have the growth indices. So if you're trying to figure out how much growth somebody's got remaining or how much of a limb length discrepancy they have, you can flip the card over and get that information as well. And so we talk about measurement types, first in terms of the axis that we're using. So there's a mechanical axis that essentially goes from the middle of a joint to the middle of the joint, or the anatomic axis that goes up the shaft of the bone. Then we can look in the transverse plane. Are we talking in the coronal plane, medial or lateral, where we measure the angle, or are we talking the sagittal plane, anterior posterior? Then proximal or distal, and then the bone type. We're only going to be talking about lower extremities here. There's a whole set of these for upper extremities as well. But so we did the F for femur and T for tibia, and then the A is for angle. So to take this through one, we have LDFA. The A there's for anatomic, L for lateral, D for distal, F for femoral, and A for angle. And then this is one of those things where you just use these words long enough and they kind of sit in your mind, just like with the hand surgeons where they use theirs. The angles were all chosen to be less than 90 degrees. So if you throw out that the LDFA is 94, you know that's an abnormal one because it should be less than 90 degrees. And that's why they did it this way. And there's a pattern that you get, especially for the anatomic angles, where approximately your medial, down to distal femur, your lateral, proximal tibial, medial again, and distal tibia, your lateral again. So there's a little bit of a pattern that sets up if you're trying to remember where should I be at a particular point in the bone. If you can remember where you are supposed to be someplace else, you can figure yourself out there. Unfortunately, this doesn't hold up for the mechanical angles, and that was just a choice they made. The lateral proximal femoral angle for mechanical is 90 degrees, so they could have gone either with medial or lateral, and unfortunately they chose to make that a lateral as well. So it kind of throws off my little pattern there. So let's talk about the bone axes for a minute. So these are longitudinal axes from which we can then make reference joint angles. There's two choices. There's the anatomic one, which is the mid-diaphyseal line to the individual bones. So if you have a femur, you choose 2 points on the cortex and a dot in between. Just do the same further down the shaft and draw a line through that, and that's your anatomic axis. For tibia, same thing. 2 dots, dot in between. And there's your anatomic axis. Mechanical axis is a little different. So you just take the middle of the femoral head, the middle of the knee, and you draw a line through that, and that's the mechanical axis. Tibia, we're going to do the same thing, just middle of the knee, middle of the ankle, and a line through that. And what you'll find is that the tibial mechanical axis is just about the same as the anatomic axis. So the two of those are pretty interchangeable. The mechanical axis of the lower extremity, though, is very interesting because it actually goes from the middle of the femoral head to the middle of the ankle and should pass just about through the middle of the knee. So that's when you know you have a normal mechanical axis when all three joints line up well. If the mechanical axis doesn't run through the middle of the knee, we call that a mechanical axis deviation. And then we'll talk about that a little bit, how to measure that and explain that a little bit more. So when do you use the anatomic axis? When do you use the mechanical axis? So on the anatomic axis, you could create a straight bone on X-ray because you'll just kind of look at more the middle part of the bone and get that all to line up. Whereas on the mechanical axis, if you're trying to straighten that up, you can actually get the joints to line up well. And I think everybody kind of gets comfortable using one versus the other. In my work, I've gotten to the point of just saying the mechanical axis is the only one I'm interested in. Because if I took this child here with hypophosphatemic rickets and I tried to just straighten out the bone with using anatomic axes, I would not be able to get the joint to line up well. Instead, if I use the mechanical axis, now I can get the hip and the knee to line up appropriately. And you'll see that the bone doesn't look very straight. The bone is actually somewhat crooked and even offset there. Kids, you heal up anything, so this did well. So let's talk a little bit more about now how to understand what a normal joint looks like. So if we take the femur, the proximal joint orientation line is done by taking the tip of the greater trochanter and the middle of the femoral head and putting a line through those. Distally, we just take the two femoral condyles and draw a line through those. And then we, again, for my purposes, I'll put the mechanical axis line through that. And that goes from the center of the femoral head to the center of the knee. It looks like that. And then I'm going to measure my two angles there. So my lateral proximal femoral angle, again, it should be 90 degrees, and that's what it is in this little sketch here. And the lateral distal femoral angle is 88 degrees. Remember, when we're talking mechanical, unfortunately, that proximal one is lateral, not medial, just by convention. So then we have our two angles there, and these measure up appropriately. In the tibia, similar kind of thing. We draw it proximally, take the lowest aspects of both tibial plateaus, draw a dot in those, and a line across that. Distally, it's just a line across the tibial plafond, and sometimes, if that's hard to see, I'll just take the talus if I know that the ankle joint looks normal. And then draw the mechanical axis to it from the middle of the knee to the middle of the ankle. Again, measure our angles there. So the proximal one is medial, so the medial proximal tibial angle should be 87 degrees. And the distal, the lateral distal tibial angle should be 89 degrees. And most of us just kind of shortcut that to 90 degrees, and that works out just fine. Looking at it from the sagittal point of view, this gets a little bit more difficult, particularly in the femur. Proximally, it's very complicated. The femur is a complicated bone to look at sagittally anyway, because you have the anterior bow. And looking at the upper part of the femur is rarely done. I've never done it in my career, and it's probably more of an academic exercise. Distally is a little trickier also. So what you do in distally is you look at the bottom third of the femur, figure that's relatively straight below the anterior bow. And you draw here, you can only do this by anatomic axis. There's no mechanical axis. So we figure out where the middle of the bone is at two sites and draw a line through there. There's our line through there. And then what we do distally is we find where Blumenstadt's line goes proximally and distally, which essentially is where the cartilaginous extremes of the femur are anteriorly and posteriorly. And we draw a line across that. And what should happen is that our vertical line should intersect our horizontal line at about the junction, the 1/3 back junction from the anterior cortex. And that line should be about, that angle should be about 83 degrees. I find this to be a difficult thing to measure, and if I'm looking for correcting this kind of a deformity in a child, I'll usually take the other side, which is hopefully normal, and use that to judge what the side I'm treating should look like. Particularly because oftentimes the things that we treat in children around the femur involve the growth plate, so Blumenstadt's line is going to be abnormal anyway, the physis is going to be abnormal, so we're just trying more to get the distal femoral condyles to line up correctly. In the tibia, this is a little easier, and we use this very often. Here what we're going to do is draw a proximal joint line that essentially follows the follows the joint line there, and then we come back about 1/5 on that line and draw a little marker there. And then we drop a mechanical axis from that dot down to the middle of the ankle, measured on the sagittal view. And it looks something like that. And so proximally, the proximal posterior tibial angle should be 81 degrees. The anterior distal tibial angle should be about 80 degrees. So these two are about parallel. And the reason for the fact that they are not both at 90 degrees is proximally this allows you to bend your knee further, and all of you guys who've done total knees know that. It's the roll back. Distally, it allows you to pull your ankle up so you can dorsiflex. It gives you that little extra room. So it doesn't look like it's a whole lot when you look at an x-ray. I've seen children with anterior distal tibial angles that are about 90 degrees, and that kind of passes by most people, but you'll notice that clinically that they can't get their ankle up very high. So it's an important angle to have. All right, so how do we now measure and define deformity? So we can start off by looking first at our mechanical axis deviation. So normally the mechanical axis lies about 8 to 10 millimeters medial to the mid-knee, or essentially through the mid-knee and up to a little bit medial to it. You see on this child here, we draw a mechanical axis, and it lies quite far lateral to the middle of the knee. So that means, by definition, this person has valgus in their low extremity. We don't know where it's coming from, so now we got to figure that out. The first thing we can do is we can measure our mechanical axis deviation. So the center of the knee to that mechanical axis line, and we just measure the distance in between. And this gives us now a way that we can discuss that with somebody else, saying the mechanical axis deviation of, say, 25 millimeters. And it gives somebody an idea of how much deformity there is. So now we want to take a look and figure out where the deformity is coming from. So we draw our little joint orientation lines, the proximal femur, proximal tibia, distal tibia. And then we place our mechanical axis lines from middle femoral head, middle knee down to ankle. We'll measure each one of our angles individually. So proximal femoral, proximal tibia, distal tibia. And what we find is that our lateral proximal femoral angle is 90. Well, we know that's normal. Lateral distal femoral angle is 88. That's normal also. Medial proximal tibial angle 87. That's normal. And lateral distal tibial angle is 89. So those are all normal. So where's our deformity coming from then? Well, the last thing we didn't look at was what's called the joint congruence angle, which has to do with what's happening in the knee itself. And this can be measured simply almost like you do with Cobb angles. And that should be about 2 to 3 degrees. You have about that much leeway in there. And in this case, that's where this patient's valgus is coming from, is actually inside the knee itself. All right, how about this one here? So here we draw mechanical axis deviation. It's 25 millimeters medial, so this means we have a varus knee. So we'll make our joint orientation lines, do a mechanical axis lines, and then we look again at a little cheat sheet over here. We say approximately we have a lateral proximal femoral angle of 94 degrees. Well, that falls within the range of 85 to 95 degrees. So that's within normal. Lateral distal femoral angle, we measured 86 degrees. Again, that falls within the 85 to 90 degree range. So that's pretty normal there too. Our medial proximal tibial angle, though, is 76 degrees. And again, that's on the smaller side now. So we know that we got some varus coming from the proximal tibia. And look at the lateral distal tibial angle, that's 91 degrees. And again, that falls within the normal range there as well. So our deformity seems to be primarily from the proximal tibia. All right, so where in the tibia is the deformity? And what we can do then, this gets a little trickier, but what we're going to do is we're going to take our joint orientation lines that are running across the joint, and we're going to draw the appropriate joint orientation angle. So going back to our little cheat sheet saying what should that angle be, and we're just going to draw that. So at the proximal tibia, it should be 87 degrees, so we'll draw a line 87 degrees down from our joint orientation line. At the tibia, we're going to draw a line up of 89 degrees. And we're going to take those two lines up until they cross each other. And in this case, they cross right at the very proximal tibia. And what you get is these, the little green line, the little blue line are the proximal mechanical axis and the distal mechanical axis, respectively. And if this was a normal limb, then those two lines would be collinear. But in this case, they aren't, and that means that we do have a deformity there. And where they cross, that's where the apex of the deformity is. That apex, so there's our proximal mechanical axis or distal mechanical axis lines. And where those lines intersect, that's called the center of rotational angulation, otherwise known as the chora. And the chora is a very important point. It helps us correct things. So in this case, if we swing the limb around, we make a very proximal tibial osteotomy, and we swing the distal limb around so that we make those two lines collinear, we've now corrected our deformity, and we have a straight limb. And this kind of keys into what Dustin's going to be talking about when he talks about Blount's disease. So essentially, again, lining up the proximal and the distal mechanical axis lines are what get you a straight bone. So let's take a look at this one instead. So we have mechanical axis deviation that we measured out. We looked at our joint orientation lines. We looked at our mechanical axis lines. We looked at our joint congruence lines. We did all that before we put up the slide. So we're just going to take all that away and get right down to the heart of it. So we draw our joint orientation lines and our joint orientation angles. And this is where they cross. So there's our chora. And we can measure our angulation. In this case, it's about 35 degrees of angulation. All right, so what can we do with that? We can just simply correct that out, 35 degrees, get those two lines collinearly, and we'll have a straight bone. So that works very well on paper. Doesn't work quite so well in real life, and we'll talk about that in a second. So how about this femur here? So we're going to draw joint orientation lines. We got our proximal mechanical axis and distal mechanical axis line, and where they cross, that's going to be our chora. Now we can measure our angulation. So in this case, it's only a 15-degree angulation, and we know where the center of that deformity is. So if we were building an external fixator, this day and age is more of an old-fashioned external fixator that actually has hinges on it that we have to place over the deformity. We'd place one hinge anterior to the chora and one hinge posterior to the chora, cut the bone about that level, and then we could use our external fixator to gradually correct out the deformity. Nowadays we have a bunch of other fancy options that we can use where we don't have to have a hinge directly over the area of the deformity, and we can still achieve our goal. And the math just gets more interesting. But again, so this is how we could correct that out, just by getting the proximal distal mechanical axis lines to become collinear, and we now have a straight bone. How about this one here? So joint orientation lines, to our joint orientation angles, and now these don't cross. So that becomes a more difficult problem. And we'll get to that one in a little bit. But that shows you, again, that we have a different way of analyzing how complex our deformities are. Now, in this case, the fact that they don't cross, that tells us, they will cross, obviously they'll cross someplace down the level of the tibia, but it tells us that we don't have a simple deformity. This is a multi-apical deformity, and it's going to take a little bit more work to figure out how to correct that. How about this one here? This is a simple deformity, so we can straighten it out just by simply cutting the bone and going across there. But one of the problems with that in real life, if we do that, is we create an opening wedge osteotomy medially and some sort of a closing wedge osteotomy laterally. So if we don't actually resect some bone laterally, we're going to be impinging on ourselves, and we won't be able to get the correction that we want. So what can you do instead? Well, you can hinge laterally. Like that. Well, that's really easy to do, except where do you need to hinge to get things to correct? Because if I chose a different point to try to hinge it, so this is now a big opening wedge osteotomy, but if I chose the wrong place to hinge it, instead of there, I decided to hinge it there, I'd have this instead. I would still have my knee parallel to my ankle, but there'd be an offset, and I'd be creating a deformity. So how do you know where to hinge it? And that introduces something called the horizontal bisector line. So the horizontal bisector line, we're going to do our usual axes, and in this case just kind of shortcut through it. So we have a proximal mechanical axis and a distal mechanical axis. Where they cross, that's where our chora is. And measure our deformity. In this case, our deformity is 30 degrees. Right, so a little bit of math here. We have a 30-degree deformity. The supplementary angle is 150 degrees. We're going to take half of that, and we're going to call that the bisector angle. And we're going to draw that angle right through there. So now we've created a bisector of the supplement of our deformity. And what's interesting about that horizontal bisector line is anywhere along that line, if we hinge, we can get our deformity to correct. Now, we already know if we hinge at the right center of the corra, we can do that without lengthening or shortening. And we've already talked about if we do it at the lateral cortex, we can get a correction, essentially just a simple opening wedge osteotomy. But what happens if we wanted to pick a different point? Let's see if we hinged across there. Well, now we can actually get a lengthening of our tibia. So if we have a deformity where we've lost length and we want to make up that length, if you use a little bit of geometry with triangles, you can figure out how far out to the sides you need to have your hinges in order to reestablish your length as you're correcting your deformity at the same time. So if we put our hinges right there, as we gradually open, we may be making that much length as you see up here, and that would help us get everything restored, not just our length, but also our alignment. Now we have here, this is more of a curved bone. It's not a bent bone, it's got a big curve to it. This would be a multi-apical deformity. This could be hypophosphatemic rickets. This could be osteogenesis imperfecta, for example. But something's got multiple apices. And so we go through the same process. Find our joint orientation lines. We drop our proximal and distal mechanical axes, and where they cross, there's our corra. Now in the tibia, it's interesting. If your corra does not fall within the bone, that's already a strong indicator that you don't have a single apex, so you have a multi-apical deformity. In the femur, if you're using mechanical axis, it's a little bit weirder because the mechanical axis doesn't actually travel through the bone. But as we already saw in the femur, if your proximal and distal mechanical axis don't cross, that means your deformity is also probably multi-apical. All right, so we have our apex here, our corra here, and we're measuring a 37-degree deformity in this case. We'll do our horizontal bisector line, and that'll give us an idea where we want to rotate. We get a correction like that. And so now we don't have a straight bone, but we do have our knee and our ankle that are parallel, and that's really what's important. What's in between doesn't matter as much. But let's say it was a very severe deformity that if you did this, you'd end up with kind of like a scalloped tibia, and that's going to become a problem for skin issues. What could you do instead? Well, make it 2 osteotomies. How do you know how much to correct then? Well, what you do is you place a arbitrary line in between. Think of this as an intercalary mechanical axis that crosses both my proximal and my distal mechanical axis. And where it crosses, these are now 2 new corras or pseudocorras. I can't remember what they actually call these, so it's my term as a pseudocorra. And we can use those now to, again, make ourselves some horizontal bisector lines. So our proximal deformity is 20 degrees. Distal deformity just also happens to be 20 degrees. If I put my intercalary mechanical axis elsewhere, those angles would have been different. It just happened to work out that way. But now I have 2 places where if I make an osteotomy, I can get things to correct with 2 osteotomies and get, so there's the top osteotomy, there's the bottom osteotomy, and now everything corrects, and I have less of a deformed bone. So it makes it, for these very severe deformities, it makes it easier to do. If you take this to the extreme, if any of you are familiar with what we do for osteogenesis imperfecta, we do the Sofield procedure where you actually make 5 or 6 cuts through a bone and straighten that out. So it's a very similar idea. Of course, with that, it's easy because you create your mechanical axis by putting a rod down the whole tibia, and you get that to straighten out. All right, so what about this one here? So here's our multi-apical femur that we saw before. How are we going to get this one straightened out? Well, same kind of idea. So we're going to make our intercalary mechanical axis. We have our 2 new pseudo corras. And what we can do is with the 2 osteotomies, first what we're going to do is make a distal osteotomy, and we're going to make our distal mechanical axis line up with our intercalary mechanical axis. Now make another osteotomy up top to align the proximal mechanical axis with the intercalated mechanical axis, and you get everything to line up here. And again, this is one of those things where playing a little bit with pen and paper or with computer programs helps to do with your pre-planning, but it at least gives you an idea of how to do it. And to be honest, when I was putting this talk together, I played a fair amount with what I was going to do with that intercalated mechanical axis. So I wasn't sure exactly where to put it initially to get the best correction. Because what you want to avoid is a lot of translation across an osteotomy site, so you have as best chance of healing as possible. All right, so what about treatment strategies? How can we get these corrections that we need? Well, not all deformities are the very severe ones. Some of these, especially in growing children, are fairly mild. They're around the extremes of the bone. And we can do this with epiphysiodeces. A hemiepiphysiodesis places something across the joint as it's growing, or sorry, across the physis as it's growing. And once you get your correction from tethering the physis, you can take that hardware out and you've reestablished your alignment. That doesn't work for everything. You can also do, obviously, acute corrections where you go in there, cut the bone, and you line it up. And that works better for the more mild or the non-apical, the non-multi-apical deformities. But for most of the things that are fun, we use external fixators. And that's kind of the common language of the deformity surgeon, is what you can do with an external fixator. Now, what we're often accused of is this. This is actually the first form of this was attributed to Abraham Kaplan, the law of the instrument. Give a small boy a hammer, and he will find that everything he encounters needs pounding, which is the same thing as if your only tool is a hammer, every problem looks like a nail. But I'll submit that there's a whole bunch of different hammers out there that we can work with, and there's probably an external fixator for every deformity that you need. And for you, there we go. Hopefully, I was hoping you guys would catch who that was. So you have choices. And we can go through some of these different choices. So we have our uniplanar external fixators. Excuse me. And these are particularly helpful around the femur, where circular fixator is a difficult thing to put on many people, especially people who've got big thighs, or just the fact that you have something that's going to make your leg much bulkier. So if you put a uniplanar one on for a coronal plane deformity, then you can get some gradual correction through that. You can see the one on the right there, the bottom pin cluster can rotate. And so if you, by lengthening out and rotating, you can correct a varus deformity. You can correct a valgus deformity back into varus. A little hard to do the opposite with. Go from varus to valgus, but it is still possible. Different forms of uniplanar ones that we can use. You can use them on toes. Yeah, you guys are very used to these, I'm sure, in the trauma sphere. This is something that I came up with a while ago for when I was trying to correct rotational deformities in femurs. It actually is a little jig that can accurately tell you how many degrees you're offsetting your pins. So you put some proximal pins in, you put your distal pins offset to the amount of rotation you want to correct, cut the bone, and then you just apply a simple rail, as you see in the bottom right corner there, and your deformity, your rotational deformity, is corrected exactly as you want it. So uniplanar fixators, very good in fracture work. They're great for lengthening if you have no deformity or have only a mild deformity, or if you have a single plane deformity, particularly a coronal plane deformity in the distal femur. The multiplanar ones, these I use a lot, less for bone deformity, more for straightening out knees. As Chris was saying, I see a lot of children with arthrogryposis. A lot of these have knee flexion contractures. So an Elizaroff is a very handy way to treat these. You can put the hinges exactly where you want them to line up with the knee well, and you can get the knee to straighten out nicely. Offshoot of this, which is now 20-some years old, the spatial frame. This has, when this first came out, this radically changed my practice because now suddenly you can play with a virtual hinge. So you can take those multi-apical deformities and you can make your osteotomy where you want it to be. You don't have to worry about where your frame's going to lie. You don't have to worry about getting hinges right where your deformity is. And you gradually can correct out. And you can correct it out in 6 different planes. It's not just its rotation, its length, its varus valgus, the anterior posterior deformity. So all these deformities you can correct out with one single gadget, and that makes it wonderfully easy to correct the kids. Problem is that you do need a computer to do this, and sometimes when you've come up with one schedule of how to correct something, you have to wait until it plays itself out before you can look at it and say, I need to tweak something a little bit differently. But I still think it's made a big difference in how I treat my patients. And it works very nicely for the complex deformities. You can stack these. A lot of people do that. It works nicely for bone transport. So if you have somebody who's got a missing segment of bone, let's say you have a tibia where you're missing something in the junction of the proximal middle third, you can put a frame on, you can cut distally, and you can take a segment of bone and transport it proximally. So you're making more bone where you're removing it from, and you're compressing it up above to get the two ends to heal together. And then there's hybrids where you have something that is a uniplanar in one area and acts more like a circular up above or down below. And that's very helpful if you need to get some extra stability. It's less bulky than a typical circular fixator, but it gives you a lot of different options on what to do. One type of hybrid is for the hip distractor. For some of the kids who have stiff hips that we're trying to correct, or somebody who's got bad Perthes disease or avascular necrosis in childhood that we're trying to stretch out the hip a little bit, give the hip some chance to heal up. Also in chondrolysis. Another hybrid type is the MAC external fixator, which Dr. Davidson over at CHOP created, and we use a lot over at the Shrine also. And this is a very good way of helping us to correct, for example, Blount's disease. It's a nice, easy one for Blount's disease. All right, thank you. It's a little faster than I thought it would be. Any questions? Okay.